Okay, our next speaker, Dr. Jones, Ted Jones, comes to us from Eastern Tennessee, where he's a private practitioner, psychologist, who has been working really on the front lines of the opioid epidemic in an area where there's a high penetration of opioid use and misuse. And he's been working with a variety of different approaches to minimizing opioid use, including virtual reality, and is here to talk to us about his experiences on the front lines of this epidemic and what we can learn from it. Thank you for being here.
Let me get clicker and make sure I'm on. So yeah, thanks for having me. I'm a clinician. I spend all day seeing patients, treating patients, and our practice, Pain Consultants of East Tennessee, tries to do it right. American Pain Society's Clinical Center of Excellence. But we're a private practice. We're not the university of something. Disclosure, I get some funding on opioid risk assessment, which has very little to do with VR and this stuff. So I'm not going to assume you know anything, so I'm going to start from ground zero. There is an opioid epidemic, and I'm living right in the middle of it. We had last week a East Tennessee opioid conference, 270 primary care physicians mainly, going over what to do about pain without throwing OxyContin all over, or oxycodone as a first-line treatment, what to do about addiction, what do you do when you have a patient. It's in the news all the time. We have headline after headline of problems. We have, I've never seen an overdose memorial Christmas tree that has all kinds, a number of families and how many families have lost loved ones to an opiate overdose. We have a counter. We have basically a body count of the number of people that have died by a day basis for each month that's calculated, and that's on websites. Naloxone you give to somebody if you think they're in an opiate overdose. Within 2 to 5 to 10 minutes, depending on how it's administered, it will reverse the effects of an opiate overdose, hopefully, with one administration, maybe 2, maybe 3. So there's also the near misses, and so they count naloxone administrations and how many administrations have we had. We try to give them to first responders, which would be EMTs, police, family members, librarians. Librarians are, have a disproportionate of dealing with overdose deaths in their public library bathrooms, and so they need to know how to administer naloxone. So there's that count. And there's the babies. Mothers addicted to prescription drugs or opiates, they deliver the baby's addicted and in immediate withdrawal, they're screaming, they're crying, neonatal abstinence syndrome, drug-dependent babies, don't call them addicted babies, drug-dependent babies. Our children's hospital just put a whole new wing on the hospital, and one of the main reasons was to have a new neonatal intensive care nursery to deal for NAS babies. So it's a huge problem, not just overdose deaths, but near misses, infants addicted, tons of problems. So this was outside my window. What's the community reaction to all these problems? A lot of that's directed at physicians. How dare you? Sometimes all too often the dots are connected. Opiates, physicians prescribe opiates. A lot of people dying with opiates, so physicians should never prescribe opiates because they're killing people. And that's really not the way the data says, but that's when you get in this mob mentality, that's what's happening. So our governor rolls out a plan. We're suing pharmaceutical companies. There's a fight between local county prosecutors and the state prosecutor about who gets to file the lawsuit. The state wants to file it, no, the county wants to file it, and they fight over who's going to be the suing. We've been trying to change pain treatment. This is a few miles away back in 2013. That's how pain management was back then. I don't see cardiologists taking up this marketing strategy. You really don't put things on telephone poles and say, come to our, they could barely spell management. But that's what we were doing. There was tons of pain clinics. So we cracked down primarily through law enforcement, raided all kinds of clinics, cut the number of clinics in the state by 2/3, cut the number in our county by 2/3. And so we've been decreasing the opioid use in our county, in the state. That's not saved lives. Our overdose deaths are going up, but at least doctors are somewhat off the hook, or at least the chronic pain doctors and pain clinics were increasingly off the hook because we've been decreasing opiates. So we've had state guidelines that have cut down opiate use and how it's recommended. Now the focus is on post-op, surgeons, orthopedists, dentists, and right now our state legislature is going through a process and they're going to pass a law saying how much opiate can you give somebody after a surgery or after a tooth extraction or a total hip, and they'll just put it in law. They've taken it away from physicians and said you all can't handle it, we're going to set some laws. So that's the current focus, is to cut down, because we all have stories of, got 90 hydrocodone after a tooth extraction and you didn't need that many. And so they're talking acute pain limits. So these are national trends. Opiate use is going down, rightly or wrongly, and there are many physicians that are trying to fight that. But I think for us, it's a done deal. Opiates are going down. So that leaves a huge gap. Matthew talked about it. We have a huge gap we need treatments for pain. So there could not be a better time for VR to be coming and providing treatments for pain. So it's not all the same, and we'll go over pain. I'd like to say, not assuming that you know anything. So pain is not pain, is not pain. And I think what I would like us to get to is not to talk about VR and pain, but to talk about VR and what types of pain. There's acute pain, trauma, procedural, post-op. There's chronic pain. After 3 to 6 months, the central nervous system changes, and it becomes a much more complicated area. Chronic pain affects 100 million people. To me, it's more comparable when you say, take diabetes, heart disease, stroke. Hello, wasn't me, but that'll get you. Diabetes, heart disease, stroke, and cancer, put them all together, chronic pain is more prevalent. Okay, it is, I think, the #1 public health problem. It's expected to increase as our population ages. There's low back pain as the #1, but there's tons of other chronic pain disorders. It's different from acute pain. It involves more central nervous system factors than regular pain. So it's a different animal. It's treated by different providers than is acute pain. It's treated in different settings than is acute pain. If you go to your local hospital looking for the pain clinic, you might find it, but you probably won't. Chronic pain is probably being done by somebody in the community and not done by hospitals. Hospitals used to have pain rehab. You check into pain rehab, just like you do substance abuse, 28-day programs. Those have decreased dramatically over the last 30 years, and now they're very few and far between. So the community has become, they're not pain programs, they're all over the place. The kinds of physicians that are treating chronic pain are varied. There's several different kinds of physicians, specialists that can be a subspecialist in pain medicine, be board certified in pain medicine. A lot of primary care doctors are still treating chronic pain, whether they want to or not. So most of it's on an outpatient basis, and what I bring that up for is for people in the development industry, marketing, distributing, and writing applications are going to be real different, because pain clinics are not all the same. One will do this way, one will do that way. They have different staffs, they have different ways that they operate. It's not like heart disease where it's really pretty standard across the nation. Chronic pain is very different. So VR and chronic pain. Unfortunately, our studies, I think, make up the majority of studies on chronic pain because it's not being studied well, VR and chronic pain. Our first study published in 2016, we just took 30 subjects and gave them a VR headset and said, what's your pain before? Asked them, did the VR experience? Afterwards said, what's your pain? And then said, by the way, when you were in the experience, what was your pain then? So there's 3 data points. We were using an Oculus Rift, gave them 5 minutes, and it decreased pain a lot during the session and a lot afterwards. 33% reduction after, pre-post, 66% while they were in there. Morphine is thought to cut pain by about 25 to 30%. So you can say VR cuts pain twice as well as morphine. Our second study, which actually was published last week in the International Journal of Virtual Reality, we took 10 subjects with neuropathic pain, collapsed the diagnoses to a general category. They were given 3 sessions, 20 minutes. So we did repeated sessions on subjects and did longer sessions than what we had done before. And we gave them a bunch of scales before and after. We had 3 VR sessions, and then these were weekly sessions, and then the 4th week we gave them a bunch of other scales. Pain ratings, same kind of left-handed check mark. Decreased pain a whole lot. And what you'll notice is between the first, second, and the session, and the third session, there was no habituation. It worked as well the third time as it did the first time. 69% reduction during the session, 53% reduction in pain immediately after. The third session was as good as the first. 97% of the time the subject said it was great, it helped me one way or the other. We said, did it help? 97% of the time. One person said it didn't help. She had CRPS of the hands. It was cool. Had a lot of snow scenes, made her hands cold, made it hurt. Next time she brought a blanket, put her hands in it, she was fine. So one person had an adverse reaction through the VR experience. Everybody else did good. There's a tail of analgesia. I'll let you neuroscientists figure out what's going on, but it lasts after they take the headset off. The average lasting effect is about 30 hours. That's about 90% of the time there was a tail, a lingering effect of analgesia. Ranged anywhere from 30 minutes to 72 hours. They came back and we said, the last time you had that, how long did that effect last? And they would say, and most people had a lingering effect. It's unclear why that is. Like I say, you get the neuroscientists to figure that out. But it's more than just take off the headset and you're right back to where you started. There is some tail of that. We also asked them pain across time. Generally, these are not significant. You know, the monthly average, what's your pain been in the last month, changed a little bit, but it was a 1-month experiment. Weekly pain and what's your pain right now didn't change. We gave them a number of psychological assessments, depression, anxiety, catastrophizing, which is making it worse mentally. Self-efficacy, the thought that you have confidence in being able to deal with pain, those didn't change. What we find is that then VR cuts pain 67%. While doing it, it helps 33 to 50%. Longer sessions seem to work better than shorter sessions. Like say our 20-minute sessions work better than the 5-minute sessions. Some analgesia remains for 90% of our patients. They don't change pain scores across time. It looks like there's a slight trend, not a whole lot. I think these studies are undone by the dramatic effect of VR for acute pain. You see that significant dip in pain scores. So when you see a slight trend, you think, I'm not really sure that's working across time. So they didn't seem to change, the VR experience didn't seem to change the psychological variables. We were kind of hoping people would get less depressed, kind of saying, okay, I've got something for my pain, this is good, I'm getting some success. No. It's like giving a pill. You give a pill to somebody, it works for a while, and then that's it. After a few hours, it's gone, either, well, or a day or two. So where that takes us is what now for chronic pain. Hello. Okay, so I've got a VR system and an app, and it decreases pain by 2/3. I'm not using it. I have no plans to use it. Even if I could get reimbursed to use it, I'm not going to use it. And again, that's why we get to pain is not pain is not pain. It has no lasting impact on chronic pain, the system I was using. For chronic pain, if you do an injection and it lasts a day or two, we don't repeat it. Same way with VR. So I need a different sort of application or a different technology of some sort. VR seems to work, but it's only temporary. I need something different. I need something that reduces pain on a daily basis, a take-home system of some sort, or something that's done in the office that will have more of a lasting impact, some sort of skill training sort of thing like that. So I'm hoping that we as a community can move beyond VR is good for pain or VR is not good for pain. Yes, of course it's good for pain. We've, like Walter Greenleaf has said, that's a done deal. We know it works for pain in general, but now the question is what kind of pain with what kind of practitioner for what kind of treatment? Because we're trying to get this integrated into our treatment system. So we need to find a specific place or role within the pain treatment program, and there's many roles that it could fill. Busy slide, but if you kind of look, let's see if I got my, oh yeah, there we go. So there's the analgesia, and you, in terms of what we've talked about already, you can begin to see there's analgesia sorts of thing, hospitalized patients, waiting rooms, MRI, dialysis, chemotherapy. There are all kinds of subpopulations that we could use VR for, and it would really help with a kind of analgesia slash boredom relief sort of procedure. Then there's burn units, procedural pain, burn units, injections, port placements. VR could be really helpful and has been really helpful and shown to be helpful with those sorts of things. There's a limb rehab arena that a number of applications are going for, of helping people increase their range of motion, have less pain and more function with that sort of thing. And there's various kind of physical therapy rehab. I went to a rehab conference and there was 6, 8 different vendors of different movement sorts of things. So motor control, which is not exactly analgesia, but it's in the chronic pain world and it's trying to increase function. There's chronic pain, you know, and that's where I live, is those sorts of things, using it with outpatients. Do they have home use? Do you treat them in the office? That sort of thing. And then the stress management, relaxation sort of thing, either inpatient or outpatient. Teaching how to do diaphragmatic breathing, how to do, basically decrease their central nervous system arousal, which will help pain, it'll help anxiety, it'll help in a variety of different things. So I'm advocating getting a more technology. I'm trying to talk to Dr. Burkhead to try to get, on a national level, when we're talking about VR, getting a taxonomy of not just having an app for pain, but having, well, what does it do and where does it fit within our system and what is it exactly trying to do or teach or both. So we need to have some differentiation in our thinking. We need to move beyond VR is good for pain and kind of get into this next stage of what's it doing and what professional is going to use it. Because that's the next stage. The models that are out there now, and I think if you're trying to find the path to go on, Matthew was talking about it, there's the inpatient residential day treatment sort of model where you just give it to hospitals, they put it on their unit, they advertise and say we're good for pain, and it's just kind of a value added to the, maybe it decreases their stay in the hospital, but it's bundled into a per diem sort of thing. There's outpatient, you could make it like injections where you do a treatment to somebody, they come in and they get a treatment of VR in some way or another, and then practitioners are paid per treatment. It could be like a TENS unit where you come in and we meet with a representative, the representative goes over the device with them, and then they take it home and use it. Maybe they can call the representative if they have problems. So there's that sort of model that is often used. Or it could be like biofeedback, where you're using it as a part of a counseling session, especially the PTSD folks. I think that's the model they've been using, is to embed it within psychotherapy. But it would become kind of a biofeedback, and you either get paid separately or in conjunction with your office visit. Or it can be like an over-the-counter, where physicians have things there and they just sell them to people, like BioFreeze or whatever. They just pull it out of the closet and say, here, we'll sell you this as a part of my practice, and you go home and use it. So we have to figure out, and I don't know that virtual reality should try all of these things. I think it needs to kind of figure out what it is. Is it a consumer product? It is a prescribed treatment? What exactly are we trying to accomplish with that? So what I would like is plug and play. I've had vendors send me VR, and it's got zip files and it's got folders, and I've got a copy, and it's like I say, we're having trouble where you just have a phone and click it into a gear headset, much less zipping and unzipping. And I've unzipped a file before, but it doesn't work, and then you call them and they say, gee, I don't understand why that works. It works in our office. I don't know why you're having trouble with it. And I just want to throw it out the window and go get something else. Ready for clinical use. There are some vendors that have sent me partially things, and here's an arm movement and the arm is backwards, and we're like, okay, that's not going to work for our patients, and they're like, okay, we'll work on that. Don't send out half-baked, half-done stuff. Get it tested and run it through its paces before you send it and ask us to pay for it. Like I said before, we need a nomenclature or a category system for pain apps. Is it a distraction? Is it skill teaching? Is it relaxation? And within relaxation, is it teaching a skill, or there are some apps where you just go to a pleasant place and you're there with the beach and you're supposed to automatically relax and there's no sound over. You know, that's like me going to the beach. My wife goes to the beach and she's all relaxed. I'm sitting there thinking about sand fleas and itching and sunburn and everything else. I can't, just being in a natural environment doesn't make me relax. Wherever you go, there you are kind of thing. So I need some kind of audio overlay that I can put on that says it's okay, breathe, whatever kind of thing. But we need a nomenclature to kind of figure out what kind of stress management tactic is it taking. I need a bank of machines. I've got one or two in the office, and that does me no good. Large pain practices are generally going to do groups. Psychologists, as a rule, hate to do groups, but there's a lot of patients, and seeing people one-on-one is not practical in the outpatient chronic pain world. We got far too many people for me to see individually, or my colleague. So I need a bank of machines. I do a group, I need 8 to 10 machines and say, okay, now it's time to let us be doing that. Hopefully you know our specific needs, understand what an occupational therapist does and what a physical therapist does. Like I say, you can't come to a pain practice and say, I've got this great thing, why don't you all use it? You need to figure out which profession you're aiming for and how they're going to use it, and how's it going to be reimbursed, hopefully by insurance. I think an over-the-counter here patient pay, there are some patients that will buy these things and if we recommend it, but I think it's going to have more traction and get into the healthcare system more if it's insurance reimbursable one way or the other in some form or fashion. So products paid out of pocket, I don't think, are going to get as much support from providers as they will if it's covered by insurance in some way or fashion. So hopefully we can work on the insurance reimbursement. As good as it works, we should be having third-party payers paying for it. They pay for oxycodone and everything else. They ought to pay for this. So that's my wish list. So I would ask you to hurry. You know, we have a severe opioid epidemic, and our patients are right now saying, I need something. We're cutting their doses. They're not getting it to start with. If they've been on it for off of opiates for 6 months, insurance will not let them restart it. It's like if you're a naive patient, we're not going to start you on it, and so a number of patients are being cut off one way or the other. They've been on opiates. Opiates was the treatment of choice 10 years ago, and now we've taken it away or cut the dose way down and said, live with it. And then we have patients all the time that say, please, give me something. And we put up signs saying, you know, we're going to do a clinical trial on virtual reality, and we have no problem with people signing up. They sign up all the time. But the future is now. For, like I say, we want developed products. We don't want half-done things. But we need it now, and hopefully come to the chronic pain world. There's a lot of work on acute pain and procedural and in the hospital. There is a whole huge world about chronic pain out there that needs the VR systems. We need more research on chronic pain. We have like 2 or 3 studies on VR and chronic pain. That's ridiculous. Chronic pain is a huge problem numerically and financially, and we need to be rolling out any number of AR or VR applications for chronic pain. So we need to get over to that realm. I think the developers just don't know where to find the practitioners because they're not at the hospital. So please come join us, work with us, send us products we can work with it. We've got a lot of patients and they need it a lot. Thank you.